On April 1st, 2020, an editorial published in the journal Obesity concluded with the warning that members of the obesity medicine community had been long sounding the alarm about the global epidemic of obesity, and that with the eruption of the spread of COVID-19, persons with obesity now face a dual pandemic threat. Dr. Donna Ryan, Associate Editor-in-Chief of the journal Obesity, current President of the World Obesity Federation, and the primary author of the editorial, is here today to talk about the particular vulnerability to COVID-19 faced by persons with obesity, the challenges of caring for this population posed to healthcare providers, and what clinicians might expect among the long-term outcomes of the pandemic. Welcome, Dr. Ryan.
Hi, Grace. Thank you for the opportunity.
I'd like to start with what may be an obvious question about the impetus for your editorial in Obesity, but why now?
I think that everyone recognizes the threat of this acute pandemic that we're under. But you know, I feel like people don't really appreciate the threat to global health of obesity. And obesity truly is a global disease. There are now more people in the world who have excess body weight and its adverse health consequences than there are people who are underweight. So it truly is a global disease, and it's a global disease that increases risk from many other complications. So it increases risk for type 2 diabetes, for cardiovascular disease, or about 13 different kinds of cancers. And we're seeing in this COVID-19 epidemic that patients with obesity and its complications are also at risk for having more severe COVID-19 illnesses. So they're more complicated patients. So this is serious, and everyone needs to know about it.
I read recently that as part of or as one of the many underlying issues with morbid obesity, reduced immunity is one of the things that can happen. And would that contribute to this population's vulnerability in this environment?
Absolutely. You know, it's important to think of obesity as not just a matter of body size, and it's not a choice. So individuals who have excess body fat can store that body fat in abnormal places. We call this ectopic body fat. And when body fat is stored in the liver, inside the abdominal cavity called visceral adipose tissue depot, in muscle, around the heart, this type of adipose tissue has a much more adverse profile, and it produces lots of adverse health consequences. Among them are a pro-inflammatory environment, a pro-thrombotic environment. Individuals with obesity have greater risk for blood clotting problems and lots of metabolic abnormalities. But the immune problems in obesity are something that we really only appreciated for about the last 10 years.
This certainly provides an unfortunate opportunity for observation. How are the conditions created by the pandemic, like isolation, restriction of outdoor activity and movement, and potential limited access to a varied diet, affecting people with obesity?
Well, I think everybody who is sheltering in place or is being quarantined in their homes everybody I've talked to has had the same response. We're all talking about what we're cooking and what we're eating and how we're comforting ourselves with food. So I think it's an opportunity to eat more, to eat foods that aren't necessarily as healthy, to be less physically active, and all of those are factors that can contribute to weight gain. This is not the time to be going on a stringent diet, however. We don't want patients to be, or persons, we don't want anybody to be losing weight right now, because we think that weight loss per se sets you up for being at increased risk for infection. So we just want people to maintain their body weight where they are. And it's not a time to embark on a strict diet.
Are there any, I'm terms, is there any situation or anything about excess body weight that would make it more difficult to identify an infection at this point?
You know, I don't think that COVID-19 infection rates are any greater in persons with obesity as compared to persons who don't have obesity. The problem is that once you're exposed to the virus, that the person with obesity has greater susceptibility to COVID-19 complications. So it's not that they're more susceptible to getting the infection, it's that they're more susceptible to that severe COVID-19 infection and the complications of it.
It seems too that the pandemic has arrived at a time when there's been heightened focus yet again on the epidemic or the global epidemic of obesity. Do you think there will be lessons that can be taken from the acute awareness of health in general related to the pandemic that will help going forward with understanding of obesity?
You know, I think it's very difficult to study this relationship between obesity and COVID-19 infections and severity right now. I think once the dust has settled, we'll be able to go into the electronic health records and really be able to tease out a lot about risk for complications of the COVID-19 infection. We know right now that the risk factors for having a more severe COVID-19 infection are age. Older individuals are more susceptible to the complications, any disease, and obesity is a disease. And then also, so when we go back in, we'll probably be able to look around and see what else is in there. The one other thing that appears to be a risk factor, at least in the United States, is male sex. So men are doing less well with the infection than women are. So I don't think while we're in the acute phase of the epidemic that we can really do a lot of studies to tease out what's going on around obesity and COVID-19. Once the dust settles, we'll be able to. If there is a silver lining at all about this in terms of obesity, it will be because people understand that obesity is not a choice, that it's a disease, it's a severe chronic disease, and that it really does impair health and puts individuals at increased risk for lots of other health complications. So hopefully we will take the disease obesity much more seriously at the end of this than we do right now. I think all too often people just write obesity off as, oh, well, they're just eating too much. Oh, those people, they're not exercising enough. It's a disease, and we need to recognize it for what it is.
Particularly, our website caters to primary care physicians, and it's clear from research that primary care physicians shy away from, I shouldn't say treating, but even dealing with this population, and yet they are, in most cases, the people who have the opportunity to see them most often. How are we helping to educate our primary care physicians on the disease of obesity?
Yeah, I think our primary care physicians recognize obesity as a disease and how serious it is. I think the problem comes when it comes to helping patients lose weight and sustain weight loss. Primary care physicians haven't been trained in obesity medicine, and they haven't even really been trained in how to talk to patients about it. So the last thing that the primary care doctor wants to do is offend his patients. And you know, weight is it can be a serious topic to bring up with patients, and it's sensitive. And the last thing the doctor wants to do is offend his patient. So sometimes doctors just avoid the discussion altogether. What we teach primary care docs is that one way to address it is to ask permission. So you can say to your patient, And it should always be framed around health. You're not judging your patient's body size. You're trying to help your patient achieve a healthier status. So you can say to your patient, is it okay if we discuss your weight and how it may be affecting your health? What we don't do is say, you have obesity or you're obese. That's not helpful. We try to engage the patient in a conversation about this. Many times patients are relieved that their doctor brings the subject up. And if they're not, if the patient says, no, I don't want to go there today, all you have to do is say, well, I understand. Let's agree that on our next visit, I'll bring the topic up again and we'll see if we can't talk about it then. The single best thing you could do for your health would be to lose just a few pounds, just 5%, to really achieve better blood glucose, blood pressure, and a much healthier profile.
Is it instructive or helpful to explain to the patient that obesity is recognized as a disease? Does that help to ameliorate some of the shame and difficulty with it?
You know, we don't have to blame the patients. They are already blaming themselves. You know, when you talk to your patient about their weight and you inquire about their weight history, which we recommend as part of the assessment, you're going to find out that your patients have tried many times to lose weight and they struggle to lose weight successfully and even more so to keep it off. I think patients are relieved when the doctor brings it up. It's empowering to patients to have physicians take their personal experiences, not for granted, but to accept what patients tell them about their attempts to lose weight and keep it off.
I know that too, one of the issues in primary care, it can be lack of connectedness with support services, and that, you know, the physician can go so far, but in a small community, how does she deal with the fact that the person goes home, A, to bad habits, B, to a home where that might not be conducive? Maybe the current situation is instructive in that it points to online support if it's not available in the community.
Now we're going more and more to online support, and that's a way to really deliver a skilled weight management to a big spectrum of patients. We don't have to teach every primary care physician how to be an obesity medicine specialist. So there are legitimate and excellent weight management services, some of which can be accessed on, I think, a very cost-effective way. Certainly Weight Watchers has a very good online service. Now it's called WW. They've gotten out of the Weight Watchers name. But there are others too. Noom is another one. And there are many good weight counseling programs that can be accessed online. In addition, there's been a big investment in the DPP, Diabetes Prevention Program, across the United States. And DPP programs are available at YMCAs and many community centers across the United States. And those also tend to be more affordable. So, so taking a comprehensive approach to weight management is absolutely critical. So what our counseling programs do is they don't just talk about food, they also talk about physical activity and the behaviors around food and physical activity. But the drivers of weight gain are many. It's a complex chronic disease. There are many things that contribute to weight gain. Sleep hygiene is very important. Stress management is very important. The medications the patients are taking are also important. Almost all the antidepressant medications can drive weight gain. Other medications that we may be taking for other chronic diseases can also produce weight gain. So getting your medications under control, and sometimes changing medications to ones that are more weight neutral is also good. But the idea is to not focus entirely on food and the diet per se, but rather to try to create an environment that sustains weight loss, modest weight loss, and over time. You know, I wish that everybody knew one thing about weight management, and that is you do not need to reach an ideal body weight to be very healthy. We need to be much more accepting of a whole diversity of body sizes. And we can, with weight loss in the range of 5% or 10%, we can really see some great health improvements. With just 10% weight loss, we can eliminate type 2 diabetes in people who have prediabetes. 10% weight loss. We can see improvements beginning at about 3% weight loss. So I'm not talking about people losing 50 or 100 pounds. We can get a lot of health benefits with achievable, modest weight losses. And that's where the emphasis needs to be. It's not about an ideal body weight, an ideal body BMI. It's all about having a health profile that's healthy, no matter what your body weight.
I would think too that the personal reinforcement that comes simply from seeing something small happen, A1C going down maybe 0.5%, 1%, or ability to walk a little bit longer during the day. Any small incremental change sort of builds the momentum, or begins to build the momentum.
Yeah, great. Thank you, Grace.
Sure. One last question. I was interested in well, first they were type 2 diabetes drugs, and now more and more being seen to be effective for weight loss. How are you seeing those integrated into care for the obese?
You know, we are making progress. We're making progress on medications for managing obesity. You know, we come from an era where we thought, oh, we'll just get the patients to lose weight and then they'll be cured, end of problem. But now we recognize that if we're going to achieve weight loss and sustain it, we need to take our medications for the long term, just like we do with our blood pressure medications. We write the medications for blood pressure. The blood pressure gets under control. We don't stop those medications. So I think we're now at a phase where we have some newer, good medications that can be prescribed for the long term. And we're right at the dawn of an era where we're going to have some better medications. Our second generation medications are coming along in about 2 years. So right now we can reliably produce about 10% weight loss with the medications we have, and with patients, you know, putting an effort around diet and physical activity. So we think we'll be able to improve that in several years with our newer medications. There are drugs in development by Novo Nordisk, by Eli Lilly, and those drugs are going to produce more weight loss. And we'll be reliably able to produce about 15% weight loss. One thing about weight loss is the more weight we can achieve, the greater these health benefits. And that 15% weight loss is a good benchmark, because we know that at that point in time, for newly diagnosed patients with type 2 diabetes, we can put those patients in remission. So that while we can get health benefits with lesser amounts of weight loss, we still want to work towards getting more sustainable weight loss, because that's how we're really going to make an impact on that epidemic of type 2 diabetes that is mirroring the epidemic of obesity.
And one final question, success rates with bariatric surgery, with weight loss surgery. I know that drugs and surgery are now factored into all guidelines, whether it's diabetes or obesity or even heart disease. Do you find it being an effective strategy?
You know, bariatric surgery it's a serious procedure. We've gotten much better with our training of bariatric surgeons and the surgical team, we've gotten much better using these laparoscopic techniques to do the bariatric surgery procedures, so that now the safety of our gastric bypass and our gastric sleeve, these procedures have safety outcomes that are actually better than laparoscopic cholecystectomy. So the safety is wonderful. And the efficacy is that they are currently our most efficacious treatments. So on average, we're getting about 25% weight loss with the gastric sleeve, and a little more, about 30% weight loss with the gastric bypass. Now, all of our weight loss treatments, there's a lot of variation. So what I'm giving you are average results. Some people do better, and some people don't do as well. But these procedures, they're serious. They are not to be undertaken lightly, but they can really produce enormous benefits, especially around type 2 diabetes. So for younger patients with type 2 diabetes who are early in the course of that disease, we now think seriously about bariatric surgery to help those patients go into remission with their type 2 diabetes. Of course, this amount of weight loss is also associated with many other improvements in obstructive sleep apnea. It's even been demonstrated in some of our registry studies to be associated with a reduction in cardiovascular events. So it's a serious procedure for a serious disease.
Okay. Thank you very much for your time today.
Thank you for the opportunity, Grace.
Grace, what an interesting interview. Thank you. Now, I know we're all eagerly awaiting news from Infection Control Today, which continues to share the latest on the COVID-19 pandemic. Frank Diamond is here now to report the updates and share an interview with Sharon Ward 4. Take it away, Frank.